Iron gulch, how hemochromatosis turns your liver into a toxic mine. Hemochromatosis is a hereditary disorder characterized by excessive absorption and accumulation of iron in various organs, primarily the liver. This iron overload can lead to progressive liver damage, cirrhosis, and other complications if left untreated. This comprehensive article aims to provide a detailed understanding of hemochromatosis, including its causes, types, symptoms, diagnosis, and management strategies. Types of hemochromatosis. There are two main types of hemochromatosis, primary and secondary. Primary hemochromatosis is a genetic disorder caused by mutations in specific genes responsible for regulating iron absorption. The most common form is hereditary hemochromatosis, HHC, which is typically inherited in an autosomal recessive pattern. Secondary hemochromatosis, on the other hand, occurs due to other underlying conditions such as chronic liver diseases, certain anemias, or repeated blood transfusions. Iron metabolism and pathophysiology. Iron plays a vital role in many biological processes, including oxygen transport and energy production. In hemochromatosis, there is a disruption in iron metabolism, leading to excessive iron absorption from the diet. The excess iron is deposited in various organs, particularly the liver, pancreas, heart, and joints. Within the liver, iron accumulation triggers oxidative stress, inflammation, and fibrosis, ultimately progressing to cirrhosis and liver failure if not managed. Symptoms. The symptoms of hemochromatosis can vary widely and may be nonspecific, often making diagnosis challenging. In the early stages, individuals may be asymptomatic or experience vague symptoms such as fatigue, weakness, and joint pain. As iron overload progresses, more specific symptoms may emerge, including abdominal pain, liver enlargement, darkening of the skin, bronze or slate gray color, diabetes, impotence in men, and irregular menstruation in women. Diagnosis. Diagnosing hemochromatosis involves a combination of clinical evaluation, laboratory tests, and imaging studies. Initial screening typically includes blood tests to measure serum ferritin levels, transferrin saturation, and liver function tests. Genetic testing can confirm the presence of specific gene mutations associated with hereditary hemochromatosis. Imaging techniques such as magnetic resonance imaging, MRI, or transient elastography, FibroScan, may be used to assess liver iron levels and evaluate liver fibrosis. Treatment and management. The main goal of treating hemochromatosis is to reduce iron levels in the body and prevent further organ damage. Therapeutic phlebotomy, which involves regular removal of blood to decrease iron stores, is the standard treatment approach. Initially, phlebotomy sessions are frequent, aiming to lower iron levels to normal ranges. Once iron stores are depleted, maintenance phlebotomy is performed less frequently to prevent reaccumulation of excess iron. Dietary modifications, such as avoiding iron-rich foods and vitamin C supplements, may also be recommended. Complications and monitoring. If left untreated, hemochromatosis can lead to several complications, including cirrhosis, liver cancer, hepatocellular carcinoma, heart problems, cardiomyopathy, diabetes, arthritis, and hormonal imbalances. Regular monitoring of iron levels, liver function tests, and imaging studies is crucial to assess disease progression, adjust treatment regimens, and detect any complications early. Genetic counseling and screening. Given the genetic nature of hereditary hemochromatosis, genetic counseling and screening are important considerations. Family members of individuals diagnosed with hemochromatosis should be informed about the condition and offered genetic testing to identify those at risk. Early detection and treatment can prevent or minimize the development of iron overload and associated complications. Research and future perspectives. Advancements in understanding the genetic basis of hemochromatosis have paved the way for improved diagnostic techniques and potential therapeutic targets. Ongoing research focuses on developing targeted therapies, such as iron chelators, to directly reduce iron levels and alleviate organ damage. Additionally, efforts are being made to enhance awareness, facilitate early diagnosis, and optimize management strategies for individuals with hemochromatosis. Prevalence and genetic basis. Hemochromatosis is the most common genetic disorder in individuals of Northern European descent. It is estimated that approximately 1 in 200 individuals of this population carries 2 copies of the mutated gene responsible for hereditary hemochromatosis. However, the condition can also affect individuals from other ethnic backgrounds. HFE gene mutations. The majority of hereditary hemochromatosis cases are associated with mutations in the HFE gene, specifically the C282Y and H63D mutations. The C282Y mutation is most commonly linked to severe iron overload, while the H63D mutation is generally associated with milder forms of the condition. However, not all individuals with HFE gene mutations develop clinically significant iron overload, highlighting the influence of other factors in the disease's manifestation. Non-HFE hemochromatosis. In addition to the HFE gene mutations, other gene mutations can also lead to hemochromatosis. These include mutations in genes such as HAMP, hepcidin antimicrobial peptide, HJV, hemojuvelin, TFR2, transferrin receptor 2, and SLC40A1, solute carrier family 40 member 1, among others. Non-HFE hemochromatosis may present with similar symptoms and complications as HFE-related hemochromatosis. Screening and diagnosis. Early detection of hemochromatosis is crucial for initiating appropriate management strategies. Screening for hemochromatosis involves measuring serum ferritin levels, transferrin saturation, and performing genetic testing for HFE gene mutations. A liver biopsy may be conducted to assess iron accumulation and the extent of liver damage. Although non-invasive methods such as MRI and transient elastography are increasingly used for this purpose. Juvenile hemochromatosis. While hemochromatosis typically manifests in adulthood, there is a rare form known as juvenile hemochromatosis that affects individuals in their teenage years or early adulthood. Juvenile hemochromatosis is caused by mutations in the HJV or HAMP genes and is associated with more severe iron overload and rapid disease progression. Early diagnosis and intervention are crucial for managing this aggressive form of hemochromatosis. Dietary considerations. Individuals with hemochromatosis are advised to modify their diet to minimize iron absorption. This includes avoiding iron-rich foods such as red meat, organ meats, shellfish, and iron-fortified products. Additionally, it is recommended to limit vitamin C supplements, as vitamin C enhances iron absorption. However, dietary modifications alone are not sufficient to manage iron overload, and therapeutic phlebotomy remains the primary treatment approach. Hereditary hemochromatosis and other conditions. Hereditary hemochromatosis has been associated with an increased risk of developing other medical conditions. These include liver diseases such as non-alcoholic fatty liver disease, NAFLD, and alcoholic liver disease, as well as cardiovascular diseases, arthritis, and endocrine disorders. Regular monitoring and appropriate management of these coexisting conditions are necessary to optimize overall health in individuals with hemochromatosis. Sharing genetic information. Individuals diagnosed with hemochromatosis are encouraged to share their genetic information with close family members. This enables them to understand their risk and potentially undergo genetic testing themselves. Early identification of at-risk family members allows for proactive monitoring and intervention to prevent complications associated with iron overload.